So the next session is focusing on the policy and advocacy strategy of ECA. And I'm really going to be facilitating, inviting speakers to talk about this work, because this is really not my work. So let's go to the next session. Most of this work I'd like to acknowledge was sort of led and conducted by Freya Sage, who was our policy, or is our policy officer, but is on paternity leave at the moment. And I've invited a few of our partner representatives to talk on some of the key policy issues that we've focused on over the last few years. So I'm going to first invite, you can't really see when you're on the stage, so I'll let the panelists sit so they can watch presentations, and then I'll invite them up to the stage, if that's okay. So firstly, I just want to talk through the few policy priorities that ECA really focused on. And we're going to hear from Freya. We forced her to do a pre-record. No, we invited her, and she did a pre-record talking through the process of identifying a lot of the policy and strategy challenges that we face around eliminating hepatitis C, and the work she did in describing them, documenting them, and then walking a small group of advisory committee members through a process of prioritization, and ending up in identifying sort of 3 key priorities for us to work around driving change in policy. And those key priorities were increasing support for peer workers to work across the Hep C care cascade. So this is acknowledging that predominantly peer workers have been funded to do harm reduction, patient advocacy and support really through the AOD or within the AOD sector, and that there's relatively limited funds and a sort of a limited history in doing peer work within the Hep C sector, the kind of Hep C space. And so there is an understanding that while they're sort of really funded through AOD, a lot of the work, at least within the ECA, is really focused on supporting people through testing and treatment. So it might not kind of sit comfortably within the funding envelope of some of the AOD work, but that's really the home of that workforce. And so just acknowledging perhaps we need to be thinking about how we better support that workforce to do some of the work around Hep C care and ensure that they do get adequate funding, and the services that employ peers get adequate funding to do that work. The second one is around reducing barriers to hepatitis C testing. So this was a really key one in 2019. I think this was sort of one of the biggest issues. We identified really quickly that testing was declining and that we really needed to remove a lot of the red tape. And so focusing on increasing access to point of care or new diagnostics, and that was point of care testing. And thankfully, over the time course of ECA, we've had RNA point of care testing now approved and widely available through the national rollout. So that's really exciting. Shelley's going to be giving us an update about a lot of the work that Asham are leading around the Roundtable and the sort of advisory and steering committees are focused on supporting access to point of care testing. And the next one is the other priority that was identified by the advisory committee was a focus on increasing testing and treatment in prisons. So Yumi Shannon from Kirby and the National Prison Hepatitis Network will give us an update on all of the work that's been going on in sort of bringing those key stakeholders together and mapping out the National Prison Consensus Statement, which is really fantastic, which was just recently released like a month ago. And then finally, Joe Doyle is going to talk us through some of the work around engaging pharmacies as a place that we can be delivering Hep C testing and potentially really adding to the referral and linkage to treatment opportunities. We know that people are accessing OST and also NSPs through pharmacies. And so there's a real potential for them to be a key workforce in engaging people in Hep C testing and treatment. So I hope that this works. Hi
everyone, my name is Freya, and I'll just be providing a brief overview of the policy and advocacy component of EC Australia. And apologies, I can't be there to present this live to you. So just so we're sort of on the same page about what we mean when we refer
Oh, that didn't work.
So it's generally considered that there's sort of two main types of advocacy. One is individual advocacy that someone might be doing on behalf of, say, a patient or a client, and the other form is systemic advocacy. And this is focused on actions which seeks to introduce or change policy decisions. So we're really looking at things like law, regulation, policy, practice. And it's through the use of these sort of active interventions with that explicit goal of influencing government policy. And I really like this sort of image of what it means and what it looks like to advocate, and all the different sort of elements that go into that, as well as the kind of context as well that you need to consider in advocating for policy change. And I guess what I'll sort of mainly be focusing on in this presentation today is really around that first box in developing a clear and unified solution. And I think that's really key to then influencing change, because without that you can have different voices saying different things and leads to decision makers being sort of confused or unclear about exactly what is the path to follow. So I'll sort of walk you through some of the process in terms of how we have sought to put together a clear and unified solution, and then some of the next steps. So when I started in 2020, the team had done national consultations. They'd gone to each state and territory and spoke with key stakeholders in those jurisdictions to ask them what were the sort of key issues and policy issues that were affecting hepatitis C elimination for them. And so when I started, I sort of mapped out what had been identified across these sort of 8 domains. And this is definitely not an exhaustive list by any means. It's just to give you an idea of some of the issues that came up. And apologies if it's not very clear. But so examples included MBS items for hepatitis C testing, KPIs for treatment in prisons, funding of the peer workforce, data linkage, case definitions, peer distribution of injecting equipment, and decriminalisation all came up. But that's obviously a lot of issues and it's not possible to advocate for each of those and put lots of resources into those. So we needed to develop a process to prioritise them and work out what were the sort of key issues that ECA Australia stakeholders could all sort of get behind, but also doesn't mean that some of these issues are unimportant or that organisations couldn't advocate for them individually. It's just sort of what we put our collective resources behind. So we put together a stakeholder group to help us work out what that prioritisation process would look like, and it resulted in a 2-phase process. So the first phase involved our internal ECA team members. We applied a decision matrix against each of those policy issues that had been identified, and that's the decision matrix that you can see there. So we used criteria around alignment with ECA Australia values, the evidence base, the potential impact of that policy change on the elimination targets as committed to in the national strategy, the resourcing needed, the likelihood of achieving that policy change within the next sort of few years. We know that some issues can obviously take quite a lot longer to achieve change, and then the existing support or the number of organisations, I guess, who we know of that support that issue. And then this resulted in a more consolidated list, which we then took to our ECA Australia Advisory Committee, which is made up of key stakeholders from across the hepatitis C and the peer drug user organisations as well as government. And so we asked them 2 questions. To what extent is this policy change important to your organisation and the people you represent to achieve hepatitis C elimination? And how beneficial is it to have a collective voice? I guess that was the sort of key of putting together issues that organisations within our network could all sort of get behind, really. So we asked them to rate that, and then this resulted in 3 priority areas, including improving hepatitis C testing, that also involved point of care testing, increasing support for the peer workforce across the care cascade, and increasing hepatitis C testing and treatment in prisons. So I won't go into detail into all of those areas of sort of what that then looks like at this point, but I'll just give you a brief summary of what we're doing in terms of the peer workforce. So we've been developing a position statement, and this is something then that organisations can put their logos on, demonstrate that support for these issues, covers some of the key issues within the sort of peer workforce and what is sort of needed. So that's things around training and accreditation, supervision, but also just sort of general kind of policy support within strategies as well. So we'll be consulting on that internally and externally. And then from there, once that's sort of agreed upon, just seeking opportunities to be advocating for that. So that could be through strategies and consultations or direct engagement with ministers, and even just seeking other opportunities to raise the profile of peers as well. So that's just sort of a brief overview, and I'll pass over to my colleagues. Thank you.
Thank you, Freya, and I'm glad that the video worked. So I do want to talk a little bit more about the peer worker, supporting the peer workforce for hepatitis C, and acknowledge that a lot of this work, at least the initial consultations, were done with Jake Docker from AVIL, who's since moved on, and also Sione and Nadia from Harm Reduction Victoria, where we're getting people's feedback, and also Amanda Kafassi from Quinn, getting people's feedback about what some of the key barriers or challenges are around supporting peer workers within the hepatitis C space, as opposed to, say, the AOD space or prevention, just simply prevention work that they're sort of funded to do already. So there's growing recognition about the importance of peers and their role in increasing access and engagement in hepatitis C care. And peer workers are largely funded in the harm reduction space in the prevention education roles to provide peer support and client advocacy, but not so much to sort of things like testing or support to attend appointments, or even ongoing patient support around maintaining treatment and getting access to SVR12s or SVR testing. And within kind of the last few years, there's now a lot more evidence and programs supporting peers to be integrated into hepatitis C models of care. And so all the work that was presented yesterday, we saw that, great example of how peers and some of our outreach nurses are working really closely together and sort of blending those lines and making really strong community and clinical team, that we're not just like doing community out there and then you step into a health service and you do clinical stuff in here, that we really recognize that the model needs to be much more flexible and a blend of that to get a better outcome. So there are new opportunities for peer workers to be trained in, say, phlebotomy and point of care testing, and offering peer support along the care cascade, particularly in place of just referring people to services, but actually supporting them through the process of testing and treatment. But to support this opportunity, we really need a better understanding of what the support structures are, clarity around scope of practice, appropriate training, building the skills and competencies of peer workers to do this work, and acknowledging the work that needs to go into like legitimizing and professionalizing people's lived experience as their asset and the value that they bring to this work. So I think we know it's sort of something that falls upon the sector to recognize their value. And I guess historically, there's always a push to try and demonstrate the efficacy, impact, and value in a very like hard numbers way. And so I think some of the earlier conversations here, well, can we evaluate the impact that peers are having on testing and treatment outcomes? And I think something that we have to not fall into that the kind of usual trope of just measuring everything against testing and treatment outcomes. And I think a whole bunch of the work yesterday really helped us realize that there's so much more than just getting somebody tested and treated. And a lot of it is around building those relationships, having the opportunity, having the capability, having the motivation, and supporting people to get through those sort of hurdles and to kind of fit testing and treatment and Hep C care into their life. And there's, huge complexity within that. So I think something that we're really keen on is ensuring that we've got a lot of those details worked out. What are some of the core competency? No, I can't say the word. Moving on. Read it in the slide. I was up way too late last night. I will acknowledge that. And we're up way too early this morning. That we recognize that, document it, and start putting it together in sort of funding proposal and asking for money so that they actually get that support and funding. There is already strong support for peer workers to be in this space in the strategies, and some of the state strategies have it really clearly identified. And what we need is all the work that goes beyond just naming it in a strategy. We know that the national strategies will be out next year, and hopefully they also reflect this strong support for peer workers in this space. And then we need to do the work to actually get them in the field, well supported, supervised, trained, and continuing to do the work that they were, that they're already doing in a lot of the regions. So as Freya said, we're working on a position statement about the role of peer workers and in outlining sort of what a well-supported peer workforce would look like, partnering with AVIL and the state and territory peer drug user organisations and hepatitis councils. And we're just in the early stages of consultation. So we'll be coming out kind of seeking more broader community feedback and then going through a process of seeking endorsement. So next presentation, I'd like to invite Shelley Kerr up to the stage to talk about a lot of the policy work that ASHM are driving in this space. Thanks.
Hi, everyone. Really honoured to be here with you all today on Wurundjeri country, and I'd like to pay my respects to elders past and present. So today I'm talking to you about hepatitis C diagnostics and some of the policy advocacy work that we've been doing with EC, as well as a lot of you in the room today as well. I've been working really closely with Freya over the last few years, and we were part of the EC Policy Advocacy Working Group. And as part of that, we talked a lot about yesterday about how the work through EC was catalytic, and this is a really great example of how some of that work that we've been doing with Freya and EC has been catalytic. Some of the things that we talked about were barriers to testing, that there's lengthy diagnostic pathways, and through that we often lose people to follow up, and we have hard to reach services, and so what are the solutions? And something that really resonated with me yesterday was Uncle Ringo's story about walking with his people on a healing journey, and currently our diagnostic pathways aren't very healing journeys. We often ask the people to do a lot of the work. They're really rigid structures, and despite all of the work that we've heard here today, these are all through grants, they're all through research projects, and what do we need to do to make our diagnostic pathways sustainable and easy to access for the people we want to help. Following the EC working group, we started to have some conversations. We've got some point of care testing projects rolling out. So we thought, well, let's get together in a room, have a round table, and nut out what are the barriers, what are the challenges. We originally planned that to be about 30 people in a room discussing it. But as we were pulling together all of the stakeholders who had an interest in improving the diagnostic pathways, it turned into a 2-day event with about 110 key stakeholders. So it was much larger, and it was a really great session. So that was a session that we held in collaboration with Hepatitis Australia. And from that, we've developed a report, a summary report of some of the themes that came out of that. So some of the key questions that we asked at that roundtable were, what are the current implementation challenges for optimising laboratory-based care testing in Australia? And what are the implementations for high caseload settings? And what are the implementation challenges for low prevalence settings? And so we had a few workshops over the days, we had some presentations, and from that developed this roundtable summary report. One of the themes that came out of it for laboratory-based testing was improving reflex testing. So some of the challenges identified was that currently we need to establish chronic infection. And at the moment, the general statement says that that needs to be 2 antibody tests 6 months apart. And then you can test for RNA. And what that essentially means is that's three visits already. And then you have to come back and get your results, and then you have to start on treatment, and then you have to come back for a test of cure. So there's a lot of steps for someone to go through from diagnosis to treatment and cure. So hopefully with the new guidelines that are coming out, we'll have some improvements in that. And the definition of chronic infection is changing. So hopefully that will make a big change. But currently, reflex testing would reduce some of those visits. Currently, the clinician needs to order RNA reflex testing on an antibody positive test for that to happen. And some other issues identified were episode coning. So episode coning is where the pathologist is only reimbursed for the 3 highest tests, and then either the patient's charged or the pathologist wears the cost of the remaining tests. We thought that this was a bigger issue than it has seemed to be. It hasn't come up through recent conversations. This seemed to be a bigger issue many years ago when we were talking about reflex testing, but to date it hasn't really shown up to be an issue, but it's something that we need to keep in mind as we're moving forward with our advocacy. And then there's also, to enact reflex testing, you need enough blood. So you either need to be taking 2 samples, or you need to be taking enough blood to have that separated into 2 aliquots. So that's really around process and ensuring that pathologists and GPs and the ordering clinicians are, making sure that they're ordering the right test to begin with, and that the blood's being taken correctly, and that when it gets to the pathologist that they're able to do the tests that are required. Now that we don't need to be doing genotype testing and we're doing more qualitative testing rather than quantitative testing, perhaps we need less blood. But these are all things that are on the table and that have been identified as challenges. I think they're all achieved. We can overcome these challenges, and Freya and Paul from EC have put together a really great policy statement, and I think that should be really ready to go soon, that we can share, and we'll be tabling that at the Policy Advocacy Working Group coming up in December. So some of the solutions to improve reflex testing, some updated guidelines. So in our testing policies, in kind of the ASHM guidelines that we developed, the GESA guidelines, we've got the new GESA guidelines coming out soon, which will help with that. But then we also, oh gosh, I'm only on slide 2, Jackie. Okay, I'll speed things up. Yeah, the GESA guidelines are coming out, which will give us some of the evidence that we need to advocate to PBAC and MSAC to kind of change the general statement and improve those diagnostic pathways. Perhaps we could consider a combined MBS item number, so that it just happens. You just order that test and then it goes on, does antibody and RNA. And then also provider education. So making sure that GPs and clinicians know to order it, also that pathologists know what they need to do at the point of testing as well. We've got some really great buy-in. So the RCPA have released a position statement on reflex testing, and Sullivan Nicolaides have also implemented guidance to all of their labs on implementing reflex testing for hepatitis C as well. So I think this is, I think we'll get a win here, and I think that probably pretty quickly. So that's really exciting. So some other things that we talked about, we really need models of care to suit varied populations, and to do that we need a range of tests available. So currently we have a RNA point of care testing, but ideally we'd love to have Hep C antibody testing. We'd love to have Hep B antibody testing. I know there's some work happening around liver function testing, DBS, having DBS approved. So really expanding our toolkit to be able to provide services in different high settings, high prevalent settings, low prevalent settings, in prisons, in GP practices, in all of the different places where we want to be doing testing, and really looking at ways that we can support decentralized testing, and we can be making sure that we're going out to the people and not expecting them to do all the work and multiple visits. We need updated guidelines, and essentially we need sustainable funding models. So at the moment, all of this work, all of these projects, you know, the models of care we heard of from Sal and the team up in the NT, you know, it's all grant-based. We need a lot of the point of care is research-based. So what do we do when those projects end? We need some sustainable funding models. So that's something that we'll be working on with our policy advocacy group. And I'm going to go through because Jackie's holding signs up at me. So where to next? We are convening a national policy advocacy working group to improve diagnostics. So we have a steering committee, which will provide leadership and oversight, and then we'll have a national reference group that will support some of that work, because there'll be things like PBAC and MSAC applications. And then we've also got an industry separate to that, an industry reference group. So they won't be kind of part of that core group, but really important because we really want them to be submitting things to TGA. We really want to know what's coming from them. So they're really important stakeholders as well. But we just have them quite separate so that they're not influencing the policy advocacy work that we're doing. So we've got our first steering committee meeting on the 1st of December, which is exciting. We'll endorse all of the terms of reference and set the path for moving some of this advocacy forward. And I'd also like to acknowledge that the funding from the Australian government, who are supporting this work as well, so that we can really get some great outcomes. These are some of our change agents. A lot of them are in the steering committee. A lot of them were part of the pulling together the national roundtable, but this isn't exhaustive. We've got a lot of people who are really engaged and will be joining the national reference group and supporting a lot of the work moving forward, which we're really excited about. And if you want to get involved and know more about point of care, and I had to give a little plug for the Point of Care conference that's coming up next year, which will be really exciting. And we've just released a point of care testing website, which really brings all of the amazing work that is happening across the sector around point of care into one spot. It's currently only got hepatitis C content on there, but we'll be expanding that into other infectious diseases as well. So that links out to all of the projects, and it's a hub essentially for point of care testing. And if you want to join our advocacy efforts, this is how to get in touch with us. So thank you.
Thank you, Shelley. And also, I just want to acknowledge you have beautiful slides for somebody who had to do them on your phone apparently yesterday. Well done. Very good skills. We'll leave questions just for the panel because we will have time at the end. So the next speaker, I'd like to invite Yumi up to talk about the National Prison Consensus Statement. Thank you.
Thanks, Lisa. So there are lots and lots of I guess, projects and initiatives that are happening in the prison sector at the moment, you know, from Burnett, from Kirby, from all over the country. And so in a 10-minute presentation, I couldn't quite cover everything. So I've decided to focus just on one of our initiatives that at the national level, which is the National Consensus Statement on the Management of Hepatitis C in Australia's prisons. First, I should probably introduce myself. My name is Yumi Sheehan. I am a research project manager at the Kirby Institute and also the coordinator for the National Prisons Hepatitis Network. And I'd also like to acknowledge the traditional owners of the land that we're on today excuse me. And acknowledge the traditional, the elders past, present and emerging. So the National Prisons Hepatitis Network, what are we? So the National Prison Hepatitis Network was established in 2017 with a goal to try and connect all of the key stakeholders from each of the Australian jurisdictions to really try and facilitate information exchange and support the enhancement of health infrastructure for testing, treatment, prevention and continuity of care for hepatitis C in the custodial sector nationally. And we do this through innovative and collaborative research, through knowledge exchange and networking activities. And we're aiming to contribute to Australia's goal to eliminate hepatitis C as a public health threat through promoting a coordinated approach to national elimination of hepatitis C in the prisons. The NPHN is governed by an executive committee. Some of the members are in the room today. And the executive committee includes members from each of the states and territories across Australia and from various sectors. And the executive committee meets quarterly. It's chaired by Andrew Lloyd and Alex Thompson and Mark Stuve. But the NPHN more broadly is quite a large network, and it involves or includes members from each of the states and territories and the sectors. A lot of you are in the room today as well. So the National Consensus Statement on the Management of Hepatitis C in Australian prisons was developed this year by the NPHN. It is the first statement focused on the prisons and the first kind of, I guess, guidelines that have been focused on the prison setting for hepatitis C. The statement was officially launched this year in May at the Viral Hep Conference in Brisbane. And it was really born out of a need that was identified for a national consensus statement from the NPHN members, which was really to try and articulate the best practice in hepatitis C prevention, testing and treatment in prisons, and recognition of the growing importance of the prison sector in Australia's hepatitis C elimination efforts. We heard yesterday the prison sector is contributing over 40% of towards the national total treatments last year. So this statement is trying to fill a gap in the Australian policy landscape. And what we've done is we've made 24 recommendations and nominated key performance targets and indicators for the implementation of hepatitis C prevention, diagnosis and treatment in the prisons based on the local and international scientific evidence. And the statement is really trying to intending to inform policymaking by the state and territory government departments with the responsibility of the provision of or oversight of the prison-based health services, including both privately and publicly operated prison health services. It is intended to be a living document, and we do intend to do regular updates in response to the changes in the evidence, policy and practice. And the NPHN hopes to promote a coordinated national approach with consistent policy, practice, and reporting. And we're really looking forward to working with the states and territories, government departments to try and progress the implementation of these recommendations, which we know is a really challenging task ahead of us. So the statement was developed by a group of authors from the NPHN. This author group included clinicians and specialist nurses, public health academics and researchers from across the country. And just a special thanks and a special recognition to Alex Thompson and Beck Winter, who really championed the coordination and the development of this statement. So we undertook literature reviews, we drafted and peer reviewed each of the sections. We drafted and discussed the wording of each of the recommendations, and we as the author group rated rated by consensus, the strength and the quality of each recommendation and KPI according to the grade system. Key stakeholder groups were then invited to provide feedback and comment on the draft version of the statement. We then incorporated all of the feedback, and finally these stakeholder groups were invited to formally endorse this statement. So I thought that I would give a couple of examples. I would love to run through all of them, but don't have time today. So just a couple of the key examples or principal recommendations from the statement. The first one is that people in prison should be offered hepatitis C testing, treatment with DAAs equivalent to that in the community. And a recommendation that follows from this is that universal opt-out testing for hepatitis C infection across all prison locations should be adopted for all people newly incarcerated. The grade rating of this recommendation was A1, so that's a strong recommendation with high evidence. And the associated KPI here is at least 75% of all people newly incarcerated should be tested for hepatitis C within 2 weeks. And an annual reporting of the number of new receptions and the total prison population and the number of hepatitis C antibody tests that were conducted as well. Another recommendation here is retesting should be offered at least annually for all those incarcerated and offered at any time for people who disclose risk factors or request testing. The grade here is B1, so slightly lower, a medium level of recommendation, a medium level of evidence, but the KPI here associated with this recommendation is that at least 50% of all people in prison for 12 months or longer are offered retesting for hepatitis C, and the reporting indices here are annual reporting of the proportion of people imprisoned for 12 months or longer who are offered hepatitis C testing. And the final recommendation here is all those identified with hepatitis C infection be offered antiviral therapy, which is a no-brainer, but it's not always happening. Very strong evidence here, high evidence here, and a strong recommendation. And the KPI here, so at least 75% of all those identified with hepatitis C are actually initiated, and the annual reporting indices you can see here are just reporting numbers and percentages. Another key principle that I really wanted to highlight here is that people in prison should have access to evidence-based hepatitis C. 3 minutes. Thanks, Jackie. That people in prison should have access to evidence-based hepatitis C prevention strategies that are equivalent to those available in the community. And this is really to support the prevention of in-prison hepatitis C transmissions, including new infections and reinfections in each jurisdiction. So here the recommendations are that prison needle and syringe programs should be implemented and evaluated. And the KPI here, prison needle syringe program is actually implemented. Another key recommendation here is that all people who are assessed in prison, who are assessed as eligible and who request access to OAT actually receive timely access to OAT. And the KPI here is, again, that OAT is available to at all prisons and to everyone who requires it. So the statement is available on the MPHM website, which is just up here. It has been distributed to all of the key stakeholders in the sector at various levels. It's been distributed to the ministerial level, the Commonwealth level. So really trying to get this into the hands of all of the relevant people. A paper-based version has been sent out to all of those people, but we do encourage you to, if you would like a copy of the statement, please get in touch with me. Otherwise, it is available on the website. We are also we've submitted an academic paper version to the MJA, which should be published over the coming months. And so I do encourage you to share this consensus statement more broadly with your networks. And we're really looking forward to working with our MPHM members and other key stakeholders to really try and implement all of these recommendations that we have outlined in the consensus statement. I would love to, I was actually planning on talking about a lot more, but with 10 minutes I wasn't able to. So sorry that these acknowledgements don't quite reflect exactly what I spoke about, but it's more broad than that. So I would just love to acknowledge all of the people who are involved in this, in both the MPHN and the development of this consensus statement. It was a lot of work, and really appreciate all of the work that Alex Thompson and Beck Winter have done to really drive this forwards. Thank you.
Thank you, Yumi, and sorry for only giving you 10 minutes. I know you spoke really quickly then. Which only took 9. There we go. We will have time for questions once we bring all the speakers up. So I'm going to invite the last speaker for this session, Joe Doyle. He'll be talking about the roundtable that was conducted recently around enhancing hepatitis C care in community pharmacies. Thanks, Joe.
Thanks, Elisa. Hi, everybody. I've been briefed to speak for 5 minutes today to pay back for last night. It's timekeeping, and the timekeepers press go. So there you go. And I'm keeping you from lunch. So I wanted to start by acknowledging that the work I'm presenting today is a collaboration with HEP Australia, with Kerry, with Monash Addiction Research Centre, with Susie Nielsen and other Burnett colleagues, Jackie and Pete and Mark. So let me just start and say, why focus on pharmacies? In some ways, perhaps I'm preaching to the choir here, but I think we all know that new models of care are needed to reach people not accessing care through existing services, and pharmacies are readily accessible to the general public. And there's some data suggesting that some individuals will access pharmacies more than any other health services, particularly people who have been traditionally found it difficult or been excluded from other health services. So, and also pharmacies are really clearly part of the health service, which really are engaging many of the people we work with and people at risk of hepatitis C, including people on opiate agonist therapy, maybe people accessing NSPs where there's co-location. And there's another series of risks that you could go through and think of how pharmacies are at that interface. And there's also, when we think of all the pilots we saw yesterday from workforce development, or at least the highlights of them, there's actually been similar work already piloted in pharmacies, both here and overseas, to show that this works. So actually, some of it's been quite formally done in randomized trials as well. And with colleagues in Scotland, we did some of that in Victoria, where we could show and that actually by offering services in pharmacy to people on opiate agonist therapy, you could increase testing 10 times and increase treatment uptake by nearly the same. And pretty much everybody who gets treated gets cured. So it's clearly a really obvious area to try and go to and work out how to access, get people to access care there. So with that background, community and us and the research partners were thinking we really need to get to start to build cross-sectoral partnerships here in the pharmacy space and answer some of these key questions. And some key questions are about where and for whom would pharmacy-based therapy be a priority? What could pharmacy-based hepatitis C care models look like? How practically, how would you design them? What would they look like? And what are the best strategies to implement them? So these key questions came together in a national roundtable, and I thank anyone in the room or organisations in the room too for attending. It was hosted by these three parties, EC, HEP Australia and Monash Addiction Research Centre virtually, because we just was easy to get to people together. And I think a few months ago, we still weren't quite in this nice, happy, mask-free environment that we are today in Victoria. We got 55 attendees there from across community, government, research, clinicians, and the professional organisations. Importantly, pharmacists were really critical to that. Both the academic pharmacists who often work in the more specialised centres where actually they're pretty well adapted usually to try and engage people injecting drugs and at risk, but also the commercial pharmacies who are actually frontline and have a very different focus and a very different priority in some respects, much more commercial focus. And we were fortunate we could get some people in the room there. So in 2 more slides, with 2 minutes to go, I'm going to tell you some of the key findings, because that was really what this talks about. It's not giving you exhaustive details, just to set some seeds in your mind to think about. There are three main themes that came out. The first is to think of pharmacists as a workforce. The second is to think of pharmacy as a setting or a location. And the third was to think about person-centered care. Now, I'll just delve into them a little bit more. So pharmacists as a workforce is to think about how we could harness relationships that pharmacists have with their community, although we did get feedback that it's not always positive, but some of it can become more positive. Could we expand existing hepatitis workforce by broadening pharmacists' scope of practice? They can do health promotion, they can do risk assessment, but what about ordering testing or prescribing or at least referring? They're questions. I don't have the answer yet. There's also a key element of remuneration for pharmacists providing these services, but also COVID was identified many times as a key area where pharmacists feel burnt out, having been at the front line with antivirals and also delivering vaccines and just being, like I guess a lot of health services, quite stretched and stressed. What about pharmacies as a setting? Well, and you can reach individuals who aren't getting care through existing systems. Priority populations often have other ways of getting services to provide outreach, like a lot of the integrated hepatitis nurses we have in Victoria and in other states as well. but different pharmacies have different capabilities and interest and might need different levels of support. But that would be one way where existing services go to that location, set up shop and help do the testing and treatment. And then there's this third element of person-centered care. And this is where the needs of community need to be married with those of the pharmacies. There needs to be dignity, respect, cultural safety and flexibility, because pharmacies are a quick environment, not much privacy. So it's addressing stigma and discrimination, particularly if someone's picking up OAT and you have to talk about injecting risks and Hep C, we know that that's tricky too. And so there has to be awareness from the pharmacist point of view of how to manage substance use, abuse and mental health. And also thinking of the other social needs, which are obviously really critical for the people, but they also are not necessarily on the pharmacist's radar necessarily. So finances, transport as well. Now, the last slide is to say that there were some, within those themes, there's these 4 broad areas that have been identified as work to do. One is coordinating efforts. So we need to get integration and collaboration with existing services and share resources, work out how we can link people together and clarify the right roles and responsibilities. Second, not in order, but second, we have to address regulatory barriers here if this is to be a long-term sustainable issue. And that's restrictions around ordering testing, thinking about indemnity insurance, which pharmacists really were key, was a critical problem for them. What about ordering rights or prescribing rights? Other countries do this, but not many. And we do this for other diseases like emergency contraception, just to think about. What about advocacy? Well, sustainable funding beyond, having shown in pilots and trials this works, is now about sustainability and building business cases and generating consensus across all sectors and thinking about how we can target state and national strategies to get this incorporated. And then lastly, implementation. We need diverse strategies to target areas with at-risk populations, and particularly geography where there might be more people who are missing out on care at the moment. We need better training and education, and we need to look at these financial barriers. Now, I'll just say the next steps in this work are the Roundtable report will be available in 2 weeks. It's out with for some consultation with some of the key partners at the moment, but then we'll go to everybody who is there. And if anyone in the room would like to get it, I'm sure Steph can share that with people. I'll make sure she has it. There'll be a next phase of the steering committee being expanded to help design the programs and models and a surveys plan to actually go to commercial pharmacists to see whether they agree with what the roundtable conclusions were. Because if we can't get commercial pharmacists in the field to give feedback, it won't work. And lastly is looking at developing an advocacy plan, which is why I'm talking in this session. And that's it.
Thank you, Joe. We are almost at lunch, but before we go, we will have time. Can I invite the panel speakers up to sit at our panel and encourage people to ask any questions around the past session? Here you go. Yes, Megan, thank you.
I've got a question for Uni. Nice to see the recommendations for the prison service. With those KPIs around, 75% of people being tested and treated, will that be monitored? And, if a prison is not achieving those KPIs, is that a way that they might be able to get some more resources in the bloodborne virus sector?
Oh, we had another. Has anyone seen the other microphone?
Yeah, thanks for the question. So we do recognise that these KPIs that we have set they're quite aspirational, and we have made this very clear to all of the Justice, Health and Corrections organisations that these are targets that we're hoping to achieve, and we're wanting to support the organisations to try and achieve these goals as best they can. If they don't meet these targets, it's not a failure on their part. It's just, as you say, identifying that there is further work that needs to happen. And so, yes, it could potentially be a really great strategy for, advocacy strategy to try and improve the services, or how can we better support services to reach these targets? But we do recognise that they are aspirational, and it's not a failure if they don't meet these targets. But it was important to set a benchmark to work towards.
I've got the next question, sorry. And it is for you too. Yeah. I really liked to see that stuff. Finally, we got stuff, like stuff for a push. It's not going to be just Dorrit pushing the prisoners around. I was looking at it and I was thinking, could it possibly be incentivized as well? So I know from when they normally go into a custodial settings, they can opt in for like a full blood screen that when they're coming in. But if they do the full blood screen and then come up with like a HCV positive test, could they possibly be given, like an incentive for that? Because I think they're only getting like $11, per week. So if you gave them $10 for that, $10 for, so $10 for bloods, $10 for starting treatment, and then $10 for like, the SVR4 or SVR12. I don't know where the funding would come back from that, but I think like that incentive process would be good, and probably everyone would take it up because I would if I was in there.
Yeah, great idea. I think that really comes down to funding, unfortunately. As part of research studies, generally, people in prison are paid for their time. Again, that varies by jurisdiction, but from a health service perspective or from a corrective services perspective, it would completely come down to budget. But I mean, it's an interesting idea, and potentially something that we could float by for some of the key people. But yeah, really, really interesting idea. Thanks.
My next question is for Joe. Really interesting initiative with the pharmacies. I mean, I'm not surprised because the Pharmacy Guild is quite active in sort of finding ways that they can kind of creep into primary care. I guess I'm slightly skeptical, and I just wonder if the panel that you put together involved any of the peers, and if it's actually acceptable to the community that would be accessing it, versus an idea that's sort of formed from professional sort of bodies. And I guess my concern would be confidentiality, and also being able to follow on people who, like how they'll screen for cirrhosis and then manage them if they're not engaged well in a primary care. I mean, I can fully admit general practitioners need to do better. And I agree that, pharmacy might be a good place, but my perspective would be more collaborative partnership with nurses and peers sort of sitting in pharmacies as opposed to pharmacists doing it all.
I think they're really important points. And I don't think that there's one model. Sorry, I think they're good points. And I don't think there's one model being proposed. And I hear your comment about how sometimes interests drive where things go. And I think there are elements of how far would be desirable, and then how far is also practical. Like, do we need in Australia, with the hepatitis C elimination plan that we have, do we need wholesale regulatory change to allow pharmacists to order and do scripts, when actually you could have, as you say, a partnership model that's coordinating and linking things up, and that could work for just 3 or 4 or 5 years to do the job that we need to get done. So it doesn't have to necessarily be that wholesale change where suddenly the pharmacist is a prescriber. Mind you, there are countries that did that, like Scotland, but they started early and they've shown that it works in that way. So I think that there's certainly a really open mind about how to do it. And that's why the two ideas of pharmacists as a workforce and pharmacy as a location are both working together, and they're sort of separate ideas too. It might be that you need a bit of both to get things done. It might depend on geographically where you are and what the workforce is around you. So at this stage, I think the whole approach is to have the Guild as one of the players, but also the Pharmacy Society, who represent the pharmacists, plus community and people with lived experience as well, who are all sort of in the tent at the moment, working quite well together to try and work out how to get through all that.
My question is regarding the pharmacies. I've been approached by the Pharmacy Guild to put out "It's Your Right" posters in the pharmacies, and one of the things the lady came up with from the Pharmacy Guild was to train all the pharmacist assistants about Hep C. So when clients are coming in and asking for a Sharps kit and see the poster, they've got the right knowledge to tell the clients. And like for the pharmacists themselves to be a little bit more trained. Like, we know that pharmacists are real busy and they're just, giving out medication, but just for certain pharmacists and certain pharmacists to be able to be trained more in Hep C. So when they're giving out those packs, then they feel comfortable to talk about it instead of just giving or as they usually do, throw you a pack and then see you later. But it'll be, I think the pharmacy thing is really good. As well with the prisons, I think it's really good that regarding the Hep C things, I feel that we need to do a bit more harm reduction with the inmates, because a lot of the inmates, when Teagues and I were doing harm reductions with the women's prison, a lot of them don't know what Hep C is, don't know what Hep B is, and even how to attract it. They think that, like, they're still very old school and think that if you're touching someone, you're going to get HIV. So even though we talk about it all the time and we know heaps about it, it's a lot, like, there's a lot of people still in the prison system that have no idea. They don't even know they're catching it half the time. So.
Thanks. Hi, I'm Jen from NTAC in the NT. This is just a question for Yumi. Just obviously we've heard so much over the last couple of days. It's no news to anyone about the value of peers and how important they are, as voices at the table. So I'm just wondering briefly if you could just outline what community consultation looked like in the development of the statement, and if you feel it was done well and has resulted in endorsement.
Yeah, thanks for the question. So the community involvement in the development of the statement was, I guess, through that review stage. So we offered review, we engaged the key peak body organisations at the national level to engage in the consultation. We received feedback, we incorporated feedback, and it was a little bit of a back and forth discussion. Ultimately, due to lots of different factors, we weren't able to receive endorsement from the community organisations for this version of the statement. We really needed to, our plans are to work together with the community organisations on the next iteration, which is kind of in the planning process at the moment, to make sure that we are addressing and including that voice from a really strong perspective. But we did incorporate as much as we could for this first round, and so there has been that community level of involvement in this first round, and looking forward to working further for the next round.
We might do one last question before we break for lunch.
I just had a quick question for Shelley. Just around testing. Is there any, movement or looking at kind of maybe phasing out antibody testing for at-risk populations or people that have completed treatment? Because I think for us on the ground, we're doing treatment with people. They're going to different doctors. We're getting a call saying, you told me I finished treatment. My doctor just told me that I've got Hep C. So me as a non-medical person trying to explain to a client that it's an antibody test and you're not reinfected. And this happens continuously. And it's a huge barrier for our clients when we talk about accessing treatment, accessing testing. If you're getting continuously told you're hepatitis C positive and having to educate your doctor, it doesn't give our clients much faith in the health system. And the amount of money that's spent on continuously antibody testing, where it could just be one PCR, and that's a huge issue that we're seeing. I probably get probably 2 to 3 clients every couple of weeks, or even a week. One time I had 3. I got a client that got sent a referral to the liver clinic from his GP with an antibody test, told his work, told his family, took the day off, parked at the Gold Coast Hospital, which is a nightmare in itself, got over there in the liver clinic, did a PCR, and he was negative.
Yeah.
It's very traumatic. It's really traumatic for people, and it's a huge issue.
Yeah. And that was brought up as well, that it's traumatic. It's also a waste of resources. So where we're looking at, those populations where there's likely to be a high level of antibody positivity, can we reflex straight to PCR? And that's one of the strategies that will be incorporated into some of this policy advocacy work.
Thanks for the question. We could probably keep going, but I thought that was a really good panel discussion. So thanks for the panelists and for the presentations, and enjoy lunch.